Hi everyone, I'm Dr. Prashanth Gandhi. I'm a medical gastroenterologist practicing at Bengaluru. It gives me immense pleasure to represent the newly formed organization called the Evolving Gastroenterologists Association. With the help of Readystock, our association would want to start off a lot of new sessions where expert gastroenterologists would deliver speech, seminar, and share their experiences on interesting topics. The first topic that has been selected is GI physiology, and the subtopic that will be discussed on is high-resolution esophageal manometry. The title is justified by none other than our famous gastroenterologist and lead gastroenterologist in Department of Neuro-Gastro-Motility Sciences at Fortis Kurula. It is none other than Dr. Zubin Dev Sharma. He has many interesting, wonderful papers in his name in this specific topic. It's a great opportunity for us to talk with Sir and get knowledge from his vast experience. So here we go. Thank you.
Thank you so much, Dr. Prashant, and thanks for those very kind words. I think I'm still learning, and I'm still, part of the process in GI physiology. As we all say, that the more you practice, the better you get in GI physiology. So, and I'm thankful to all of you for being here, on a Sunday evening, and it's a tremendous response I see, and a tremendous interest I see for everybody for GI physiology. So I'll just share my slides. Are my slides visible?
Yes, sir.
Okay. So again, thank you so much for giving me this chance to speak on this topic. So for everybody's interest, what I will try to do is first talk of the esophageal manometry. Then we'll move on to rectal manometry if time permits. I'll go slow. I'll try to go into detail of each areas of it, just because rather than from a conference way of talking where you can just do a rapid talk, I think this would be going in much more in detail. I will not go into the basics of the equipment that much. I think for that you can go online on YouTube. There's a video. I think Ryan can share the link to all those videos, and that covers the equipment part more in detail. But here I will try to actually go more into the clinical physiological part. That is, I think, more important for us to learn. So what I will try to do is understand how our esophagus actually behaves. What are the motility dynamics there? What is the spectrum of manometry? What it can do? We all actually start and end at Chicago classification, but what I want to bring into the understanding is that Chicago is a classification of a tool, and the tool is manometry, and we have to understand physiology, imagine the patient's symptoms, and try to explain them using our tool, and then fit Chicago into that particular. What we should not do is, try to fit the whole concept of GI physiology into a single standard protocol. We'll go beyond it. We will talk of some therapeutic applications, and I'll also briefly cover a few topics which are not in a standard way, but I think what we can learn from them. So coming to the first part of the actual esophageal motility dynamics. So what does our peristalsis actually happen? So there are three kinds of peristalsis in esophagus. One would be a primary peristalsis, then secondary and tertiary. I think this is all we all know. But what is more important to know in them is that primary is triggered by your voluntary swallows. That means that when you're actually swallowing, whether it's water or solid, you are triggering a primary peristalsis whose work is to progress the contraction downstream towards the ileus. The speed is around 2 to 4 centimeters a second. That's why the bolus usually goes down in a matter of around 7 to 8 seconds on average. The secondary peristalsis, on the other hand, is triggered by distension and some irritation. And that's when it actually happens, it can cause pain, it can cause symptoms. It is never initiated with the actual swallow, and these are but also progressive ones. So what do they work physiologically is that after you had a primary contraction, you have basically pushed the bolus down. So this secondary contraction happens to clear the esophagus of whatever is left inside. Is basically kind of a clearance wave. But in what physiological conditions would actually trigger it? For example, if you have a food bolus stuck somewhere around the lower esophagus, there is some eosinophilic esophagitis, or there is some motility disease there itself, you will trigger more of secondary peristalsis because the food will be remaining there, and the lumen will become distended. How do you test it? I'll come in the subsequent slide. The tertiary contractions are physiological contractions, but in a pathological state, they tend to become exaggerated. If you will look into a very early eclasia or very early DES, you will actually see, beautifully on a barium or a gastrographin, good amount of tertiary contractions. Important part is that they are non-progressive. They will never propel the food down. They are non-peristaltic. They are spontaneous always. So these three are seen in they have different physiological works, and they are they get abnormal or they get exaggerated in different pathological conditions. Now, if you actually look into a good barium swallow, I just run the video multiple times for you to understand, because it will all these contraction will happen very, very fast. So the first bolus down is actually triggering the is because of the primary peristalsis. As I have paused this right here, what you can see, these waves happening are a mixture of secondary and tertiary waves. Tertiary waves, because you can see all these are non-propulsive waves. But if I again run it through, some of these contractions will become propulsive, and that's when it becomes a secondary peristalsis. But the first bolus is coming down is what we call the primary peristalsis. So in a good barium swallow or a gastrographin swallow, you can actually see all the three together if you give close observation. I just move, yeah. So how do you do, what's the clinical correlation to it? So there's different kinds of peristalsis. How do you want to check it? So if you want to check the primary peristalsis, that is the swallow-induced peristalsis, you do a manometry in them. And that is what you are doing or checking when you do esophageal manometry. You are not looking at any other contractions, but if case they occur, they are almost always pathological. Next thing is, if you want to look into secondary peristalsis, you could do something called the endoflip. Now, endoflip is a different technology altogether. What it does is it takes a balloon, a CRE kind of a balloon, which has sensors placed on it, and it gives a graded distension to it, and it takes out the response of the esophageal wall, that means the secondary peristalsis, and gives it an index, something called the distensibility index. And you use this parameter or metric, like you use IRP in your manometry, you use DI, and you classify various disorders of esophagus using DI, that is the distensibility index. Now, if you want to look into tertiary peristalsis, till now we don't have a real technology to use or identify it. The only way is what I showed you on a gastrographin swallow. But we do not have a metric. We do not have any clear data or in which and how and with which pathological states we can actually use this as a abnormal marker. So that's why there is so much to do in GI physiology. We are barely, scratching the surface, as you said. So what we're only doing is the first part in India right now. What the world is doing, first and the second part. Third part is untouched across the world. So when we come down to, we all know of liver function test, we talk of renal function test. There is something called the esophageal function test, because what you are trying to identify is function of esophagus. The first thing you want to do is a manometry. Second thing you do is an HRIM, which is high-resolution impedance manometry. That means you combine an impedance along with the manometry. That gives you a different dimension altogether, because what are you adding to HRIM? You are adding the behavior of the bolus, and you track the bolus to the existing manometry. So that gives you an extra metrics, and all those patients with rumination, with belching disorders, with supragastric belching, you can easily diagnose, or even a cricopharyngeal retrograde dysfunction using HRIM. Endoflip, I already told you. Now, high HRUESM, that means high resolution upper esophageal manometry or high resolution pharyngeal manometry. Now, this has been there for many years. I'm sure even with Readystock, the equipment is available. Internationally, it is available. There's a different kind of or a different designed, catheter to do a pharyngeal manometry where you have sensors till the pharynx. Ideally, this is supposed to be done with a solid state catheter because you don't want rapid swallows happening at the level of UES with water itself, but you can actually do it with water also give by doing some modifications to it. Even ENT people are not really using it, but its applications are huge. Now imagine a condition where you have a case of transfer dysphagia, and you have all seen these patients running around from neurology to ENT trying to identify themselves, whether it's a central cause or a peripheral cause. You will see patients who have myasthenia gravis. You will see patients who have other disorders, but you are still not able to diagnose what is the exact reason behind it. So HRUES or high resolution pharyngeal manometry will also help out in that regard. I'll show you some images of that also. 24-hour pH impedance, I think you already are aware of, you already do in your practice. It basically checks the pH and the refluxate into the esophagus. It will also look into the non-acidic reflux into the esophagus. It will try to look whether your symptoms are matching at the time of reflux or not. So it will help you to actually objectively say that the symptoms of my patients are being caused by the reflux or not. So this is also very easily available in India. And Bravo is again a good device, but unfortunately still not in India. It's a wireless extended duration device where you can keep it for almost 4 days, 5 days, or even 7 days, and you actually measure the pH of your esophagus. It's not an impedance device. So, what coming to indications, dysphagia without mechanical obstruction is something which you all know. Endoscopically, normal dysphagia, first thing you want to do is manometry. But I go more beyond it. I think we can do it much more. Even in cases where there is some mechanical obstruction, like for example, you have an early stricture, but your scope is possible. Patient has dysphagia. How do you explain that to him that I'm not going to dilate you because my 12 scope is possible, but patient says I still have dysphagia? What will you offer him? Will you offer him more of amitriptyline or something else? So you go in with your manometry and you actually see whether that small Schatzki's ring or an anastomotic site is still open, but not yet, endoscopically closed. But is it causing changes in the peristalsis? If it is causing changes in the peristalsis, you at least have some, backing of offering them a dilatation with a CRE. In the bygone era, we used to do empirical dilatations in cases of eosinophilic esophagitis. You used to do those boogie ones very easily. There was no evidence. The endoscope was passing rapidly, but you could still dilate them because they were still almost always be symptomatic. But can you actually see if there is a peristaltic abnormality happening? You can still offer them some dilatation. GERD and non-cardiac chest pain is established indications now. You have to diagnose patients with jackhammer or DES. In GERD, I think we all keep on talking of doing 24-hour pH manometry only. It really pick up GERD. But I think one of the it is almost mandatory that you have to do esophageal manometry also to diagnose, not only diagnose, but you have to see the effect of GERD on peristalsis. For example, if you have LA grade B and more esophagitis, you want to know whether my patient has impaired motility or not. This information will tell you to plan your surgery. For example, if I have a Hill's grade 2, 3 hiatus hernia and I have an impaired motility, I will not offer them a surgical fundoplication or a complete fundoplication. I might well offer them an Arma, an arms, and probably even Gerdex. Gerdex is as good as a partial fundoplication. So this information is important. So it's not only impedance that you have to do manometry also, because you have to diagnose and plan intervention depending on what these two tests will tell you. Systemic diseases with involvement like sclerosis, scleroderma, one of the first organs to get involved is esophagus. I have had patients who had no other organ involvement, only thing they came up with dysphagia or heartburn, actually, GERD symptoms. You do the manometry, they have absent peristalsis and hypotensive LES. Ultimately, you end up diagnosing scleroderma. UES is again, I already told you. Pharyngeal, I have already told you. This is the best for GERD, I have told you. Now you have already done everything. You have your poem done, you have your fundoplication done, but a patient is coming back to you with more symptoms. How do you assess them now? Will you say, okay, the gastrographin is? I have seen like yesterday, I had a patient, a surgery done for GERD, young guy with fundoplication, dysphagia, endoscope is possible, barium is possible, very unobstructed, and so then says, oh, my area is fine. And the moment you put in your manometric catheter, you pick up absent contractility, and you say that, okay, something more has already happened. I would have not done a complete wrap in this case. So all these things will actually come to you in your practice, are already coming to you in your practice. So let's just, after we have understood the range that what a manometry can do for you, let's go on to the actual test itself. So I always put this slide in my almost all my presentations, because we have to acknowledge what we currently do is legacy of Dr. Ray Claus. He actually, gave the color to the manometry as we know it now. We almost always used to read those line diagrams, and what he told us that, okay, he used to study this topographical maps of Himalayas, and if you see these topographical maps, how they designed is that more the height, the color changes. For example, the highest mountains around Nepal are white in color, and the plains in India are green in color. So similarly, he changed this with our lines. So the higher the pressure, the warmer the color. That means black, red, and lower the pressure, blue is the cooler is the color. So basically, you are using the same concept or logic from those topographical map into a manometry, and this simple concept was given by Dr. Ray Claus, and finally it completely changed the way we do manometry now. Of course, there are other people also who have done a lot for it. We had sensors starting from 4, and now we are almost around 36 sensors definitely, and sometimes we are now talking of high definition manometry where the sensors will go up to 256. So I think the times are exciting to come beyond. So catheters are broadly of two types. We have some of this may be a repetition of what you already know, but just because I'm sure there must be some postgraduates there who are not, who don't know about all this equipment or don't have this equipment at their centers, who just to cover for them. So water perfused and solid state catheters. Solid state is what the world has been using and recommending for across many years now. And important point to know is that the guidelines that you now follow, Chicago and everything, is based on solid state catheter. They categorically say that, but they add a line by saying is that in case you want to use water perfused catheters, that means almost 600 installations in our country, you have to have your own normative values on that equipment. So remember that if you are going to use a water perfused equipment, which most likely all of us are going to use, we need to have our own normative values. For Readystock equipment, it is available, done by Dr. Srinivas in Chennai, and that data is still available with us. And the first surprise there is that IRP for us is not 15, it is 13. So there are a lot of variables that our own values actually change. So water perfused catheters are also till that almost 36. They have a water flow rate. They are less expensive, but they are more cumbersome in the form that they keep getting blocked, or the flow is not right. So a lot of variables that go wrong with the water whereas the solid state ones are in case sensor, everything else has to be changed. This is how a solid state catheter actually looks like if you have done that. A water buffer looks like this. You have all these capillaries, you have this pressure sensors, and water has to flow in all of them. In case the water is not flowing well, your sensors will not work. In almost all the equipment, you have these kind of things. The Readystock has done a lot of modifications in them to make your life easier. Now, as I said, for the equipment part, there's one more presentation which all of you can see. I'll put somewhere in the link in the chat box probably later. But how to actually get the test done is you have to make sure that your standardization is let me put it over here. Your standardization has to be done at the level of patient's chest. If you have standardized your catheter or at a much lower level, for example, somewhere here, your baseline pressure should be much more lower. If you keep it higher, your baseline is going to be much more higher. So when you actually put it in, if you have standardized somewhere here and you put it in the patient, your baseline patient's pressure will come abnormally low here. That means your IGP or intragastric pressure will come low here. If you keep it here, like standardize here, and then put the catheter in, your pressures will be falsely higher. So make sure you are standardizing at the level of chest, and your whole of your capillaries are also at the same level. That's the first part of it. This is how it looks like. You raise the whole bowl, and the video will look like this. Video is not running. 1 second. Yeah, this is how it will be looking at. Now all the sensors are working together once you raise the bowl at the same time. So this is the first step to check. If this is not like this, you are not able to see all these sensors working together, please do not proceed with your test. Recheck all your capillaries, all your sensors, flush them well, and then redo the whole process before you go in. Now, this is a normal esophageal manometry. Now, we usually say is that esophageal manometry, or for that matter, any manometry, is like a ECG. You will never find a normal ECG. You'll always find something wrong or the other. If you remember your MD days, there was almost always something abnormal in ECG. The same goes for manometry. It's almost never absolutely bang normal. So even this is a beautifully normal manometry. I can still pick up some artifacts here and there. For example, all this green areas, these contractions are artifact. So, but what you have to see when you look into a good manometry. So there, how I learn it, or how I have learned it on my own, is that there are 3 parts the way I divide it. The first part that is just below the UES, this part is made from the skeletal muscles. So I call it as an S1 part. It transits into the S2 part, which is the mid esophagus, again of smooth muscles. And then it goes, the peristalsis slows down as we approach the LES, and then it comes to a what I call as an S3 part. It's this part. Now, all this has a reason. We all know the proximal 1/3 is skeletal, and then there's a transition zone. The area where the skeletal muscle transits to a smooth muscle is you will usually have a less kind of a contraction happening, because you're giving a handover to the next set of muscles. So the power or DCI or a contraction here will be actually weaker. And in a lot of patients, you will actually see a peristaltic break here. No contraction at all. In this particular example, you can see a contraction here also, but in most of the patients, you will see a peristaltic break at this area. Once you start coming to the S2, you need to have a good contraction. If you are having a peristaltic break, that means no contraction in S2 or S3, it is almost always pathological. Next comes this your S2 area. It has, as it approaches the LES, it mixes with the gastric muscles. It will encounter a strap of LES fibers, so the peristalsis has to slow down here. If it does not slow down, it will hit a closed LES, and your patient will have dysphagia. That is why the peristalsis needs to slow down. And the place where you can point a marker, like in this area where the peristalsis has slowed down to its maximum and now is changing a direction to this area, is where you will put your contractile deceleration point. It's simple English, contractile deceleration point. That means that the contractile front, that means your pressure front, your peristalsis, is decelerating, and the point at which it decelerates to the maximum is your CDP, contractile deceleration point. Now, there are some rules behind it. Ideally, it is as near to the LES as possible. That means within 3 centimeters of LES. It can't be in the mid esophagus. Why? Because in mid esophagus, your peristalsis will not slow down. It will slow down as you come to the LES. Usually, it has to be minimum of 30 mm Hg of isobaric contour. That means that a contraction should be minimum of 30 mm Hg. You can't say, okay, I'm going to put it on in this area, because that's not even a contraction. So it has to be 30 mm Hg. Now, once you have pointed out the CDP, now you have to put in the other markers, like you have to tell the equipment where has the swallow initiated. Now, sometimes you will have a patient who is giving multiple swallows. Patients will not listen to you. They will keep on swallowing dry swallows, and then you have a hard time in trying to identify which swallow has triggered a peristalsis. So that's where we have to be very, very sure where we put this marker where the swallow has initiated. And finally, this box, that is the proximal limit and the end analysis limit. These markers have to be put, and your horizontal line here should be above the LES. Why it is important? Because as you calculate DCI, now DCI is the power of your esophagus. Imagine DCI and imagine a weightlifter. Now the Olympics are going on, so imagine a weightlifter. He has to lift weight. So your DCI is the power of your esophagus, how much heavy lifting your esophagus can do. So your DCI has to be calculated in this rectangle. LES should be out of it. Your LES should not be part of your area where you are calculating DCI. Now imagine, again, we can go back to Olympics. Imagine Usain Bolt, so many gold medals in 100 meters. So it's a rapid 100-meter race. Now this equates to distal latency, DL. What is DL? Your line from your time period from initiation of swallow to the CDP point. And as I told you, your peristalsis has to slow down. But if it is an Usain Bolt and happening so fast that it's coming somewhere here, it will encounter a closed LES, and patient will have dysphagia, because esophagus wants to empty out quickly, but LES is not yet ready to receive it. So imagine your DL to be your 100-meter, Usain Bolts, and your DCI to be your weightlifters. So that's how you identify these markers. Now coming to the most important elephant in the room, the IRP. I think IRP they have a lot of confusion in what IRP is actually. IRP, number one, is not your LES pressure. IRP does not mean LES pressures. IRP is integrated relaxation potential. So what it basically means is that once you have taken a swallow, in those next 10 seconds, what was the lowest pressure at the level of LES, which was continuous for 4 seconds, or even if it is non-continuous. So in simple terms, what it means is that once I have taken a swallow, what is the lowest sustained pressure that my LES is achieving? It is not normal LES pressure. So normal LES is at a resting state. While I'm talking, I have a LES pressure, I have a US pressure. Once I swallow, my LES and US have to open. So if it opens, what is the lowest pressure it has achieved? So that is our IRP. And IRP, if it is more than what the world says 15, basically means that our LES is not relaxing as a whole. It is not achieving a low enough pressure to easily allow the food to pass through. So your LES may be still decreasing in its baseline pressure, but if it is not emptying out as much as it should, you will have dysphagia. So IRP is your lowest pressure for 4 seconds in the 10-second window after a swallow. Why this 10 seconds? Why not 12? So it can be sometimes in patients, you can see even particularly in patients who have a smooth muscle disorder, it can be even more than that. It can be your 12-second window. It can be 15-second window. Patient may be swallowing, but the LES may be relaxing at a much later stage. You may ask why, how many of you know it is actually IRP of 4, but studies have also been done for IRP 2, IRP 6, IRP 8. So why do we say this 4 second? So when we say 4 second, we are saying that at least 4 seconds are required for your food to go down. If anything less than that, so IRP 2 does not equate well with dysphagia, IRP 4 is equating well. So that's where these standard definitions came. And all these values came from Chicago 2, because Chicago 2 and 1 was basically for method, and Chicago 2 actually tried to explain IRP much more in detail. Now we are in Chicago 4 right now, and Chicago 4 had done a few changes. Every iteration of Chicago has done something new. As I already told you, Chicago 1 was basic method. Chicago 2 told us about IRP and LES. Chicago 3 a bit more of bottom of used ones. But now Chicago 4 has given us a few more things. It has defined EJG outflow obstruction in a beautiful way. It has given clear-cut criteria of what will be EJG outflow obstruction. It has said that we have to test in both supine and upright position. That means in a primary and a secondary position. Now, if you do upright as primary position, your secondary position becomes as supine. It has also told that we have to do solid test swallows or provocative measures like MRS as well as RDC. MRS is multiple rapid swallow, RDC is a rapid drink challenge. So you begin with your primary position, you stabilize for 60 seconds, you take 10 swallows after you have established the LES with the 3 deep inspirations. You take 1 MRS. MRS is done by how many? 2 ml of water given 5 times in a rapid sequence, and you want to look into the contractile reserve. This is the reserve. So MRS is I'll try to tell you what is the difference between MRS and RDC also in a later slide. In the upright position, you do the same thing. You change the position. You again standardize, which you can do automatically on the equipment. You document the position, baseline 30 seconds, and you take at least 5 ml of 5 swallows of upright. And then you do an RDC. RDC is done with a 200 ml of water directly with a straw to the patient. So, and if nothing is observed and you still want to do more, you have to do provocative measures. So, what most important thing that comes out from this testing, the number one, what I feel, and I want to make it very clear, is it is a dynamic testing. That means that while it is getting tested, you have to, as a doctor, have to be physically present there, because you will decide when do I have to do upright, when do I have to do provocative measure, when do I have to do solid swallow. So it is completely wrong for your technician to do the test and then call you, okay sir, test is done, now please come and report it, because half the battle is already lost. You were not present there when the test was being done, so automatically you will not again call the patient back, okay, let's redo the whole thing because I want to do an MRS. So please do your own test, because until you see the testing in supine and upright, you won't be able to go beyond it. Now, this is how the whole testing or one single test will minimum look like: 60-second adaptation, the 3 deep breaths, baseline, and everything. Now, I'm often asked a question of PIP, or how do you know you have crossed the LES in doubtful areas? So PIP is nothing more than a pressure inversion point. Again, simple English, a point at which pressure inverts. Invert means your intrathoracic negative pressure converts to a positive intra-abdominal pressure. That's an inversion of pressure. So as soon as you cross the diaphragm, your pressure will invert from negative to positive. And that point is called as in PIP. Usually, it is at the level of LES. As we know, LES is made up of two areas, the LES fibers or the diaphragmatic crura. Sometimes it is at the LES level, sometimes it is at the diaphragmatic crura level. And that's where as Indians, we love our typing, so we start typing them type 1, type 2, type 3, type 3B. But it is nothing more than this. Where is our PIP? LES or crura? And that's how all the classification changes within 2 centimeter, more than 2 centimeters. So, but there's no real clinical value of trying to learn this classification. Just identify the PIP, because again, this is the dynamic test. While you are there, you have to check whether I have crossed the PIP or not. Because if your technician has done and they have not crossed the PIP and the whole test is done, the whole test is invalid. You're not gone into the stomach to do the test. IRP, I've already told you. I think what is abnormal, we have to know that these values are from Chicago, but for us in Readystock equipment, the IRP in supine is 13. But if 15 gives you your peace of mind for medical legal cases, you can use that. But you will have some cases which will be borderline, and there is published data from India where our IRP is 13. DCI, I've already told you. Remember the weightlifters, their turn is yet to come for the medals, but that's what DCI means. So if you have a DCI more than 8,000, you tell it as a jackhammer or a hypercontractile. Again, Indian value is 6,000. If you have a DCI of less than 450 or less than 500, it comes as a weak peristalsis. Less than 100, failed peristalsis. So if your patient's peristalsis is powerful, a good heavyweight lifter, you will show 6,000 and above. If it's not so powerful, it will show less than 100. Latency, that means DL. Remember Usain Bolt. If it's very, very fast, it will show DL of less than 4.5. If it is very, very slow, it will be. So the slowness is not really pathological, but the fastness is. So isobaric contour, I already told you, 30 mm of Hg should be there to be called as a peristalsis. Now we learned the basic metrics. We'll talk of a bit of abnormalities now. We all know Chicago 4 divides into disorders of peristalsis and disorders of EJG outflow obstruction. So the first point of differentiation is IRP. What's my IRP? If you have a high IRP or I have a normal IRP, and that's where I will start, analyzing. Let's start with that. Eclasia is one of the probably the easiest things you will diagnose if you are using manometry. So in first thing, you have raised IRP. You put in your catheter, you will see three different patterns. The first image you see right above is a type 2 eclasia cardia, where you have a high IRP. You have something called as a pan esophageal pressurization, and you have LES, which is not relaxing at all. Now, what is PEP? So from MD days, I hope everybody remembers atrial fibrillation. So what happens is that you have mitral stenosis, and your atrium is kind of contracting in a very haphazard manner. Exactly what happens here. You have LES, which is not relaxing, and the esophagus, the whole muscle is trying to generate pressure to push the food down as a symptom, and that's where it's kind of fibrillating together, and what creates is a pan esophageal pressurization. If it is too tired to do so and it's failed, it will start to dilate, and finally you will develop a type 1 eclasia where you have no contractions and just high IRP. Okay. In type 3 eclasia, which is a phenotypically different disorder, why I say, because it's totally a different kind of disorder. Even if you look into the neurotransmitters, it is because of more of nitric synthesis not being there, so it behaves differently. You will have a raised IRP, so you will have an obstruction, but you will have peristalsis. But this peristalsis will start creating different compartments in the esophagus, mostly in the lower esophagus, where there will be high pressure, and this high pressure will cause pain and dysphagia. So this is where we call as a compartmental pressurization. So all the three disorders are actually different, and we are coming out with a paper on the basic pathophysiology and how it translates to manometry. I think that will be an interesting read, but where we go from the neurotransmitter of all the three different ecclesia types and how it actually reflects on the manometry itself. Sorry, yeah. So now, you can also use manometry to assess patients where you will see a poem or balloon has already been done. You are seeing a lot of patients now because all across India we are, somehow ecclesia has become an epidemic in India, but everybody is doing poem. So you will see a lot of patients who come to you back after a poem or after a balloon. So you will see all these different kinds of contractions or peristalsis. So you have to assess whether it's an IRP is the problem now. That means the LES is still the problem, or the esophageal body is the problem. And your surgical planning would be depending on what do you find. This is a paper by us for on post-poem assessment in using manometry in JDE, and that can be assessed. It is open access, so everybody can read through that. Now, an example from that patient, like this patient, we did a poem, and you see that the poem has been done well. You have a long 10 centimeter myotomy, but unfortunately, it's for the type 3 ecclesia, and patient had a muscle which extended to almost 14 centimeters. So those 4 centimeter or 3 centimeter muscle is left behind, and that's what is seen on your manometry itself. So you will again either do a redo poem. Now, endoscopists will say, no, I've done well, but I'm not sure whether this is what you were saying is right. Fine. So we give them some muscle relaxants. You could give them a PDE5 inhibitor, and you see that contraction going away very, very beautifully, and patient becoming asymptomatic. Again, it proves what we are trying to see. Now, the only issue is how long will patient be on PDE5? So, but ultimately, they will need to have a redo poem. This is examples of jackhammer. It's of 3 different types, or the manometry will come as a 3 different types, like a double peak one, a single peak one, or one which the whole LES is contracting and actually merges with the LES. So all 3 will behave almost similarly. Some minor differences in that the double peak will be more younger and the longer one will have more dysphagia, and all this will classify as jackhammer. And they published this in gut and clinical gastroenterology that there are 3 different types of jackhammer, and they do have a slightly different behavior clinically also. This is distal latency issue. That means that this is the Usain Bolt. You can see the rapidity of the contraction happening. The peristalsis is happening too fast here, and so it hitting almost a closed LES, and you will see this kind of a barium. Also, I'll rerun the barium again for you. And this is your tertiary contractions, which are really augmented here, and this patient will also require poem to go ahead. Now, EJG outflow obstruction, I told you it has been redefined in Chicago 4, so I will just cover a bit more in detail. It says 3 criteria. One thing is that you need to have your manometry done in both supine as well as upright, number 1. You can't just say EJG based on a supine position. Second thing, the patient should have symptoms of dysphagia. And third thing, that there should be no other abnormality which should be explaining the same symptoms. So what it means is that 50% of EJGs, when we suspect, are usually artifactuals. You have LES, which is of type 3 or type 2, with a small hiatus. The water is getting accumulated, and you start seeing images like the one you are seeing in the first image. But the moment you change the position to upright, all that water which is accumulating in the hiatus goes down into the stomach, and the pressure goes back to normal. So what we were seeing here is a false EJG outflow. It actually turns out to be a normal peristalsis. So whenever you are suspecting EJG outflow obstruction, please be very careful of fulfilling the 3 criteria. That means change your position. Your patient should have symptoms, and there should be no other explanation. So I usually wait for 6 months before I label somebody for EJG outflow obstruction. In GERD, I already told you in the beginning, this is how ineffective motility looks like, and you have a hiatus hernia. In this patient, please do not offer them a complete fundoplication or do a multiple rapid swallow. The moment you do a multiple rapid swallow, you will actually see whether there is a peristaltic reserve or not. And if there is peristaltic reserve is there, then you can offer them proper fundoplication. If it is not, you offer them a partial wrap. Otherwise, these things will develop. If you have done your wrap, it's a tight wrap, and patient is having dysphagia, and suddenly the pressures are high, the IRP is high, and this will be post fundoplication dysphagia. You will have once in a while a patients who will say that my fundoplication is done, I do not have dysphagia, but I have something called as a gurgling in the chest. So what is actually happening is that there is a compartmental pressurization. It's kind of behaving in the type 3 eclampsia. So you have a compartmental pressurization at the level of the wrap. So water or whatever bolus goes in there, and some gas from the stomach will come up and it will cause a gurgling sound which will remain in the chest. It will reflux back into towards the UES, but the UES will also not relax well now, and you will have a sound of a gurgling. So this will how it will look like. You will have a failed peristalsis, a decreased bolus pressure, a bolus pressurization happening in the distal part, and finally you will have a gurgling sound called as a retrograde cricopharyngeal dysfunction. In this image, you see is a classical for a systemic sclerosis. That means absent peristalsis and hypotensive LES. Remember this image in your head. Just memorize it. Moment you see this, order your panel for autoimmune antibodies. This is nothing else than sclerosis. The only other explanation to this image is if you have a poem which was type 1 and you have done a myotomy in them. That means that LES is now gone. These are the only two clinical indications where this image will come. Third possibility is severe GERD. Severe, I mean like LA grade D status where is completely gone and is a hiatus. But even then, this kind of a classical image will not be there until it is slowed up. Now we go beyond Chicago. This is all was partly covered in Chicago. We go beyond it. So I talked to you a brief about UES. Now UES is a altogether a different animal here. The problem with UES is that it is protecting the airway. So it has a basal tone. It opens in a much faster way and closes in 0.25 seconds. So it's not like it's not like LES where we look into an IRP of 4, 6, or 8. Here you have contractions which are fast. It depends on the peristalsis coming down from the pharyngeal constrictors. So from the pharyngeal wave, the way LES will depend on the esophageal peristalsis, UES will depend on peristalsis coming from the pharyngeal constrictors. So the moment you have a good pharyngeal stripping wave, that means a good pharyngeal pressurization wave, your UES will open. I'll not go into the too much of technical details here, but similar to esophagus, there are metrics available for UES. UES IRP we look at 0.25 seconds and not IRP 4, and there are similar metrics like DCI for pharyngeal muscles also. But you can use this test to identify patients where you can do intervention. For example, you have a cricopharyngeal bar. That means the patient UES will not relax very well. Now identify whether this is cricopharyngeal bar in an elderly is because of an osteophyte or it's actually a muscular problem. If it's a muscular problem, it will be reflected on manometry. You can inject Botox. This Botox can be injected very easily by our IR guys or our ENT guys using simple ultrasound guidance. Even we don't have to do it, and they routinely do it in their practice in OTs also by our ENT guys. So you can use this. You can also use the same thing for other indications, like if you have 10th nerve palsy, you have a case of a transfer dysphagia and patient is not there's no clear diagnosis. You can do a manometry and actually show that pharynx is not contracting at all, and you can diagnose your patient. Coming to functional esophageal disorders, rumination and gastric belching ideally require an impedance testing, but you can also utilize manometry to diagnose them. In the first image, I'll just show you this because it's a nice image. So this patient is a rumination, disorder. Patient had swallowed, but then intragastric pressure increased, the 174 value here. When the intragastric pressure increases, the LES opens up, the bolus goes up into the mouth. You can see the UES is also opening here. The bolus goes up into the mouth. And then he is re-swallowing it back. You will see a good peristalsis. So this is your rumination syndrome. On the right side, what you are seeing is a gastric belch or supragastric belch, because patient is contracting their esophagus and again bringing it out. So you can use manometry, but sometimes it may not be very, very easy, but you can use this to pick up these cases also. It's a wide world, I can only, in 40 minutes, I can just show you a brief glimpse into it. But to look at all the images, you will not find them in Chicago anywhere. You will find them when you keep doing all those tests. Sometimes you will not have explanation. I still find cases where I can't explain some contractions happening which are not artifacts. Like this in the second image, this patient actually, it was planned for endoscopy and a manometry for dysphagia. For lack of time, I directly did manometry first. I did not put in my scope. I saw this contraction. I was surprised what is happening there. Because if you see the background color, it's too much dark blue. That means my sanitation was not proper. But this contraction suddenly came at very, very high pressure. So that means there was possibly a mass somewhere in the mid esophagus which came into contact with one of the sensors and it picked up this high contraction. I put in a scope and there was actually a submucosal bulge, there was a leiomyoma. We removed the leiomyoma and finally all these contractions went away. Similar other findings you can find, but all this problem is that when you go to conferences, you talk on conferences, you'll see guidelines. None of this is mentioned, so you can't really put your diagnosis in front based on just this test. But they are useful. So, what I will tell everybody is that don't use this as the only test possible to you. Let this test be a technology available to you as a tool which you can utilize to guide your clinical judgment, and then do some ancillary tests. For example, in this leiomyoma case, we did an endoscopy, we did a CT, and we picked up. Similarly, you will find out other cases where manometry will guide you what to do next if you can't explain your symptoms. Because if patient has a dysphagia, there has to be an explanation to it. And manometry will find in almost 90% of those cases. Let's see some cases if we can try to solve this. What do you think is this? Okay, this is not a one-on-one thing, so I'm not. Let me just explain. You see, LES somewhere here. The LES is relaxing. IRP is not increased, most of them, but you are seeing a PEP, pan esophageal pressurization, happening in the esophageal body, and there is a contraction happening in the distal esophagus. Now, what was this case? If we did multiple swallows, ultimately it came down to these kind of contractions also. How do you explain them? You go back to the history. This patient basically had a sleeve gastrectomy for bariatric surgery, and he was not willing to tell us the history. Only when we went ahead and poked around, he gave us the history. When you have a sleeve gastrectomy, you will have something called as a post-sleeve gastrectomy dysphagia syndrome, and this is actually what looks like it. Your IRP will not increase, but patient will start developing PEP. These are very, very difficult to treat. Some of them. Another case, similar case, you can see there's a small hiatus here. You can see two different parts of this is the diaphragmatic crura and this is the LES part. And again, you will see a PEP. Now, what this patient was basically, as I told way in the beginning, an impending stricture. And because of the diaphragmatic hernia, because of the reflux, patient was having a impending peptic stricture. Scope was possible still, but patient was having changes in the peristalsis. So we did a CRE dilatation for him, and then finally referred him for a surgical repair, both for peptic stricture as well as for a hiatus hernia. So these patients you will pick up in your practice. If you see that, this kind of an image, you will clearly see that there is a hiatus, there is a abnormal peristalsis. So something is mechanically obstructing here. to cause a change in the peristalsis in a case of a hiatus hernia. So, just to broaden your minds, now think of a CA esophagus. What's the first symptom that comes with them? Dysphagia. So that means that every mechanical obstruction, whether it is a mass or it's a stricture, changes the physiology. That means the anatomy will change the physiology. So a physiological test like manometry will tell you if something abnormal will come on them. So if you have such images, go back to the patient and try to identify if there is a mechanical thing which is causing. So again, beyond Chicago, and this as just think of manometry as a tool and not just to diagnose ecclesia. So last few slides, I think this is what we all know. I'm keeping it here because it's still something which we all should be reading. I'll not read it each line of it. I think you can go back to the theory part of it. And but this is Chicago's algorithm, which we all should be aware of. So to conclude, I think esophageal function test is one of the most important tests for evaluation of a lot of symptoms that patient may come up with. And accurately done is HREM is vital for your interpretation, and it has widespread applications in multiple disorders and all difficult GERDs, endoscopy negative dysphagia, pre-foregut surgery will need manometry, and its application are increasing every day. We just need to create data from all of us so that that can be included into Chicago and not just say that let's only diagnose motility disorders. So thank you so much. I think I'll just end it here and we can take it from there.
Thank you, sir. Thank you for the wonderful eye-opening session for most of us. Your experience speaks in your talks. All your comparisons, the synonyms that were used, the Olympic stories, and also like how physiology can actually predict a future anatomical problems. Phenomenal, sir. Really eye-opening session for most of the beginners here. Fantastic, sir. Thank you. So straight away, we'll go to the question and answer session. So some of the questions are already in the chat box. So I'll just go through a few. Some of them are coming during the sessions itself. So let me have a look, sir, and we can answer a few.
Thank you.
I'll just shall I read it from?
Yes, sir. Absolutely, sir. Here it's taking time.
Yeah, okay. Can you please repeat the S1, S2, S3? So yeah, so S1, S2, S3 is what as I showed you in the images. The S1 is the proximal 1/3 of esophagus, that is your skeletal muscle part. S2, S3 are basically your mid and distal esophagus together. Why I say S1, S2, S3 is to make it easy to understand. I think it's not in the books, but it's what I learned in my own head. When S1 merges with an S2, that's the transition zone. This transition zone is basically where the skeletal muscle will convert to the smooth muscle. And usually you will have some peristaltic break or some kind of a low contraction happening at that area. S3 is as we approach towards the LES, and usually you will have a slowed peristalsis here. Any kind of breaks in S3 are almost always abnormal. Hiatus hernias, L grade B and above esophagitis, any kind of injury at the level of LES will usually give rise to breaks in the distal esophagus or the S3 part. How do you mark the proximal limit? So proximal limit. So what we are trying to do with proximal limit is we are trying to understand or create a rectangle where we will calculate the DCI. So usually this is only in the S2 and the S3 part. It's not in the S1 part. So you will put your proximal limit at the level of the transition zone where the S1 is going towards the S2. So you will leave the S1 out of that box. So proximal limit is at the level of transition zone. The vertical line is at the initiation of the swallow, and the end analysis line is where the LES augmentation. Okay, I didn't talk about the LES augmentation. So as the S3 part comes down towards the LES, that peristalsis merges with the LES. So you will have what we call as a post-swallow augmentation. That means that the swallow is augmenting that LES. Where that augmentation ends is where actually you will put the end limit. So that will complete your rectangle, and finally you will calculate your DCI. How to set intrabolus point? Intrabolus point, there are two methods to it. One thing is, if you are trying to identify intrabolus pressure, you have to put it at the 30 mm Hg contour at least. Otherwise, if you're looking at a compartmental pressurization, you have to put it behind the CDP, below the peristaltic wave. How do we define types of OGG morphology? I already told you that, but it's not really clinically important. So you have two parts of the LES, that means the LES crura and the diaphragmatic crura, the LES muscle and the diaphragmatic crura. When they are within 2 centimeters merging together, they are type 1, or at to within 2 but slightly away from each other, type 2. More than 2 centimeters, type 3. Type 3 is type 3A and type 3B. A means that the PIP is at the level of diaphragmatic
LES.
crura. B means at the level of LES crura. But having said that, it has no clinical role in any disease. So it's your choice to remember if you want to remember it or not. So please explain 30 mm Hg esophageal contour. So the Chicago basically told us that to classify as a peristaltic pressure or peristaltic contour, it needs to be minimum of 30 mm of Hg. So that's why we use a 30 mm pressure to classify a contraction on the graph as a peristalsis, because otherwise you will have a lot of artifacts. For example, you will have coming if there is an elderly person, the arc of aorta itself will show you some contractions happening. The cardiac peristalsis will come, it will show some contractions happening. None of them will reach that 30 mm Hg. If there is a 30 mm Hg pressure, it definitely means it's a contraction happening somewhere, or a extensive compression happening, which is certainly abnormal. In ecclesia with baseline pressures of LES is less than 13, can we expect IRP of in ecclesia with baseline pressure of IRP? Oh, okay. So you mean to say that if my baseline LES pressures are less than 13, can we expect a higher IRP? So usually, if you have a baseline pressures of LES which are low, that will usually IRP will not go beyond that value, because as I said, IRP is a relaxation of that LES or minimum LES pressures in that 4-second window. So if your IRP is already less than 10 or less than 13, so your LES is already less than that, your IRP will not go above that. Can you measure the length of myotomy to be done? Definitely. In fact, we should be doing it. We have a paper in DW this year, DW in I think the Washington one, and last year also it was published. In type 3, it is well established. You have to do your myotomies based on your manometric decided length of the involved muscle. I showed you the case where we missed out on a type 3 ecclesia and there was a proximal bar. But even in type 2 and in type 1, I did not show that slide in this presentation because I wanted to keep it a more basic one. So even in type 2 and type 1, not all LES would be same. Some LES will have a high pressure zone of 2 centimeters, some will have 3, some will have 4. Now the standard teaching is that when you are doing poem, you reach LES, you go 2.5 centimeters beyond toward the gastric side. If you go more than that, it gives you more reflux. That's the standard guideline that currently we all follow. But the problem is, if you have a intragastric high pressure zone of, let's say, 3 centimeters, you will ultimately leave some muscle behind. So by manometry, at least decide that once I reach the LES, how many centimeters I'll go beyond. That will give you your good results. Till we have endoflip available to us in India, that's the only way you can actually tell how to choose your myotomy. Post-poem assessment by Chicago 4, no. Chicago's first line is that patient should not have undergone any foregut intervention, whether it's a fundoplication, balloon, or a poem. So you cannot use Chicago for classification to diagnose or pick up post-poem or post-fundoplication dysphasias. That's why all those studies where you try to see IRP, they say okay, poem has been done, but IRP is still 15. Absolutely makes zero sense, because IRP will never be, really. You can have an IRP of 7, but patient may still have a dysphagia. Important point is whether on manometry LES is relaxing or not, and you have muscle somewhere left in the body or not. If that is there, whether IRP is 6, 7, 8, or 10 is still abnormal. Okay, a management of jackhammer and DES. So jackhammer and DES, I usually start them on PD5 inhibitors or calcium channel blockers to begin with. And then finally, if I'm sure of the diagnosis, they are responding to those drugs, I offer them poem for a long-term basis. Some of the DES will evolve into eclasia. Background dark blue basically tells me that my standardization done was lower than my patient's anatomical position. That is why it's possibly that that it's too low. So what happens is that once you go in, your IGP will be too low and your IRP will become falsely high. How to set or change contours? So you mean the pressure isobaric contour? I hope yes, you can change it if you want to change it. There's a provision to it. You can decrease to less than 20 if you want to. Sometimes we do it for really highlighting the pressure as well. Can we have an elevated IRP due to large hiatus even in secondary position? Yes, you can. That's why I said EGG of flow obstruction should be given a test of time before labeling them as EGG of flow obstruction. And the commonest reason for having elevated IRP with a normal peristalsis is actually large hiatus hernia. How to differentiate type 1 eclasia and absent contractility? IRP high with absent peristalsis is type 1 eclasia. IRP normal or low with absent peristalsis is absent contractility. Type 3 eclasia and DS. Okay, this is my favorite question. So this can be sometimes confusing. Distal esophageal spasm will have a normal IRP, but the DL will be less than 4.5. That means that the contraction is rapid. Type 3 eclasia will have high IRP, compartmental pressurization, or premature contraction. So they may have a shortened DL, but the IRP will be high. So IRP will differentiate type 3 versus DES. How to keep catheter in eclasia when it coils? Yes, so if you have a type 1 eclasia, dilated esophagus, you will have a hard time. Change the position to upright. Ask the patient to continuously swallow. Do some maneuvers. You ask the patient to do the maneuvers which they do to bring the food down. Sometimes that works out. You can do a screwing movement of the catheter to take it back, the way we do for ERCP when we have to cannulate the biliary strictures. If nothing works, you can put in an ultra slim scope on the side and try to push it down. There are wire guided catheters also available. Please explain PIP. PIP is, as I said, pressure inversion point, where the negative intrathoracic pressure converts to positive intra-abdominal pressure. So remember your basic physiology. Diaphragm is your border. Above it is the lung. Below it is your abdomen. Your lung needs to have a negative pressure to bring in air. Your abdomen needs to have a positive pressure. So the diaphragm differentiates them. So the moment you cross your catheter into the stomach, you have crossed your diaphragm. And the point at which this pressure inverts on the manometry is called as a PIP, usually at the level of LES or diaphragmatic cruda. Is 10 swallows mandatory in upright? Ideally, yes, but Chicago says this 5 is more than enough in secondary position. So it depends. If your upright is your primary position, you do 10 in them. If upright is your secondary position, at least 5 in them. Is upright or supine, which is more important position? So both are equally important. So there are people, Dr. Srinivas does only in upright. He doesn't do supine. His primary position is upright. So it depends on what you are comfortable with. Is 10 swallows mandatory in supine? Yes, minimum 10 swallows should be done. Why? Because if you read Chicago, the classification diagnosis is based on percentages. 70% of this, 80% of this. So you need to have 10 to define percentages. Can we do upright test with that water perfused? Yes, we can do them. We have been doing them. Any modification in software baseline? No, not for upright. You just have to do the standardization again once you change to your upright position. Please demonstrate 30 ml. I think I did show. RDC with 200, is it mandatory? So RDC 200 ml with straws is what is to be done. It is to be used in patients when you are suspecting EJG of flow obstruction and you are not able to clearly pick it up on your normal swallow. So you challenge the esophagus. So yes, I talked of to how what is MRS and what is RDC. Both are different things. And MRS, you are giving small amount of water, that means 2 ml of water, but rapidly. So what you are doing is trying to see whether your esophagus have enough reserve. So how do you check that? Once you are giving something rapidly, your esophagus will just behave as a recipient, or it will just be there and stand. It will wait for your swallows to finish, and then it will generate a peristaltic wave to clear it down. So if it has enough reserve, it will push that flow down towards the LES. What does RDC does is that you challenge the esophagus with so much of volume, that means 200 ml of water in esophagus, that it has to change to almost a simple conduit tube. It will stop all peristalsis. It will just become a tube. Itna pani aa raha hai, so it will, it just can't use peristalsis to like put it down. So 200 ml water, if you challenge rapidly, it will just behave as a simple tube for water to go down from the mouth toward the stomach. So in patients where you have an LES abnormality, like means EJG of flow or eclasia, they will not be able to tolerate it, because they will not be able to tolerate 200 ml of water in the esophagus itself. A normal person or a normal esophagus will convert to a simple transfer tube. So the water will go into the stomach directly. So that's why an RDC is done to pick up subtle LES abnormalities, whereas MRS is done to pick up esophageal body abnormalities. So both are different tests to be done for different purposes. I hope it's making more sense. When do we do perform solid food swallows? Solid food swallows is to be done when you have a patient, where water swallows are not picking up LES abnormalities. You may challenge with a more stronger peristalsis, because the moment you put in a solid swallow, you want a higher DCI to work. But at the same time, it will also challenge your esophageal body. So usually in patients where EJG of flow obstruction, where things are not clear, you may give some solid swallows. What is a rescue protocol? What are we rescuing? I'm not sure what is a rescue. Maybe you can tell me. I'd like to learn. Rescue protocol. I just do a provocative test. I don't do a rescue. Maybe like missing out on something. What is an intrabolus pressure? How to diagnose EJG? I think I already told you. After doing the solid state, I have to keep the marking in different position. Can it like marking in different position? I am sorry, I didn't get the question. After doing a solid state, I have to keep the marking in different position. I'm sorry, I'm not able to I'm not sure what you are referring to. Can you please ask again in detail? Post-surgery lab fellows, what is the IRP cutoff for again, we don't know. I think if patient is symptomatic, patient has dysphagia, and you say that LES is visually not relaxing, your IRP is somewhere around 15, 16 or more than that, you should start thinking of a tie trap. Do a barium and or a gastrography and try to see the emptying of esophagus, put in a scope, look it for resistance. But if everything else is normal and only manometry is showing a borderline IRP around 16 or 17, start thinking that maybe 6 months down the line, this patient will develop a full-blown dysphagia. What is low LES mean in scleroderma? Low means that to the normal LES pressures somewhere would be around 25, 30, at least 30, somewhere around that. If you're having a very visually low LES pressures, an absolute value of around 10, less than that. And I'm not talking about IRP here, I'm talking about the baseline LES pressure. If it is around 10, 12, 15, less than that, start thinking of scleroderma. In eclasia, many times it is difficult to pass. I think already told you that. Where to keep CDP and proximal type in eclasia? I think I already covered that. recording of the manometric measurement could be done by manometric technician, should be done. I think it has to be done by us. As I told you, it's a dynamic test. If you are not going to be there, see, for that matter, a lot of our technicians are even good at, might be good at endoscopy also. I know a lot of good technicians who can easily do endoscopies, like sometimes better than us. And in some of the centers, they can even do ERCP. Will you leave all that to them? Then why are we here for? I think we should not be, we should do all our tests ourselves. And lack of time is not you will not say that I will not do endoscopy for lack of time. In patients with Parkinson's dysphagia, what is yes, very important. Parkinson's disease involves a lot of things. It will involve your pharyngeal muscles, it will involve your UES, and it will involve the S1 part. That means your skeletal muscle part. And you will see in patients that the S1 part's contraction becomes lower, the pharyngeal push becomes weaker, and they usually have a transfer dysphagia. It can be drug induced also, depending on what drugs they are taking. I usually do manometry in them of the UES after I have ruled out an LES disorder. Then I do for UES. So look into the pharyngeal part, look into the UES part, and look into the S1 part for them. Management of ineffective esophageal motility. Treat the cause. If GERD is the cause, you treat the cause. If it is scleroderma, you treat that. If it is eosinophilic, you treat that. If nothing else works out, you can still use some prokinetics, but they don't really work much. How useful is manometry in post-eclasia? It is very useful, but don't use Chicago for them. Use more visual impressions of what you are doing. How to treat IAM or absent contractility? I already told you that. When to do rapid drink challenge? I think I told you. Type 3 IAC can sometimes have a normal IRP. How we can be different than from JACM? So there is a variant of ecclesiocardia where it has been published to what we call as a low IRP variant. And how we can differentiate from jackhammer. So sometimes it can be very confusing. Some of the jackhammers may actually have a high IRP, and some of the eclesias may have a normal IRP. The issue is that why are we fixated on IRP in them? If you have a jackhammer or you have a type 3 ecclesia suspected, both of them, the ultimate treatment would be to do a myotomy in that involved area. The treatment does not differ in both of them. Usually, a lot of variables are there. For example, where you place your LES, your placement of LES in type 3 or jackhammers, your LES marker may sometimes be cumbersome because they will have the longitudinal muscle of the esophagus will contract, and that will pull the LES up in those patients. So sometimes you may have a falsely low IRP while you're putting the marker. But as I said, if it is like in some cases, it may get really difficult to characterize them very, very well. But even if you are not able to, doesn't matter because the treatment in both of them, medically and surgically, remains the same. In DCI measurement, any role of post-sleeve gastrectomy? Yes, normally there is an absent contractility happening, but this happens late in the post-gastrectomy dysphagia syndrome. So post-gastrectomy dysphagia syndrome is classically absent contractility, and there is some pressures at the IRP. Sometimes it can be confused with type 1 ecclesia also, but the clinical setting is clear that you have gastrectomy and then you start developing dysphagia. But early on in this course, you may have a PEP like a picture also. Can you show in the image how to measure MRS DCI, where to keep proximal and end swallows? Okay. I think I did show you the DCI in MRS. There was one image there. I'm not sure. Let me see if I can again show you. Okay, this one. So here, if you can see the slides, I have kept the first 5. My early the start of swallows is here when my first swallow starts. My end swallow is where the last swallow ends, and then the DCA will be somewhere in the box where the peristalsis is being visible. This is how you actually do in your Readystock equipment. So I hope this is clear. Okay. In my institute, I see my technician after doing the managed solid state. The color graphic. Okay, you asking again this question? Yeah, color graphical representation. The horizontal and vertical lines are positioned manually, but I do not understand from him where. Okay, you're talking of the various lines. So as I told you in those slides, in the proximal limit and those limits. So see, every software will have a different some basic differences. The broad thing is that you have to tell the software where does my swallow start, where does my S2, S3 segment start and end, and where does my LES starts and ends. This much information you have to give to any software, whether using a Readystock or doing something else. So proximal limit, that means the vertical line you're asking about is basically where my swallow starts, and the end line is where the post swallow augmentation of LES ends. Let me again show you the slide. If you give me 2 minutes, probably I will show you that in the slide itself. Okay, 1 second. Yeah, this one here. So if you see here, this is, you have of initiation of swallow. This is my proximal limit. That means where the transition zone has starting. Then this is the end analysis, because this is where my augmentation is ending, and my lower limit of the LES becomes the lower limit of that box. So this rectangle is where you will put all your DCI. So your vertical line and horizontal lines are basically like this. The transition zone becomes the upper limit. The LES upper line becomes the lower limit. So, your S1 proximal swallow here, where the IRP starts to go down, becomes the proximal limit, and where the post swallow ends becomes the end analysis. So this is where you will put in your markers.